Okay, quick video on to kind of finish up on our asthma COPD respiratory emergencies. This is going to go into more of how do we assess these people, or how can we assess to kind of indicate that one of these emergencies is likely happening, and then what can we do about it, and how can we differentiate. So let's talk about that. And if you think to your patient assessment, we're going to start with the scene size up. Now, obviously, um, you should be able to get dispatch information for this, but sometimes we can't. A lot of times we're just dispatched for a sick one. That's legit all the info we get. One of my rules is that the patient shouldn't have to say one word to you in order for you to do your job, which means we shouldn't need to have outside input from other people. We shouldn't have to rely on anybody else for us to do our own assessments effectively and accurately. So let's see what we can do with the scene size up. Let's look at the environment. Now, what do you think might be present in someone's house, in someone's car, or something, or just with someone that could indicate that this could be COPD or asthma? Well, how about treatments, evidence of treatments, or medicines that treat these? So, like if you walk into a house and there's a big O2 tank, or a big cord of oxygen tubing, huge indicator, obviously, that someone needs supplemental oxygen. If you see inhalers, if you see a lot of tissues, these folks will cling to their tissues as if those tissues are giving them oxygen. They will not let it go. And then I always think, yeah, no, that's good for the environment. And then let's do the general impression. Age could come into play, right? Ooh, how about up here? Cigarettes was a big one. Or bongs. Or vaping. So age is a big consideration. Remember, asthma, you're likely looking at someone younger because it's a younger person's disease. Not all the time, but most of the time. And then COPD, you're probably looking in your late 40s, early 50s, something like that, and older, right? That's just my experience. And then we get, after age, let's look at their, and this is as you're like walking into a room, let's look at their position. How are they standing or sitting? These folks will not tolerate laying flat. They'll be either standing or they'll be sitting upright. Up. Not sitting relaxed, sitting bolt upright and likely forward, what we call, and they'll be in both positions. They can go tripod. Oops. And that is, they're sitting with their hands on their knees. And what this does is this allows their chest wall to expand farther than if they were leaning back and had something back against them. These people, again, will not tolerate laying flat. So their position, how they're holding themselves, and they're not looking down either. They're going to be looking up like that. And I know that's kind of a little detail, and I wouldn't expect anyone who's very new to this to catch that, but after you've been doing this for a while, you can really pick up on these little tidbits. So their age and their position. Let's go into the ABCs: airway, breathing, circulation. So airway. One of the biggest things that we can do to assess the airways is to listen to it. You can hear audible wheezing. And that's more of a breathing thing, but this is as you're approaching, you can hear it. We can hear airway congestion. We can hear coughing. So the sounds. Breathing should be silent. The breathing itself. Now, every time you assess breathing, you assess the rate, regularity, and the quality. We'll talk about a couple irregular breathing patterns, I'm not super concerned that you know about them truly. I'd rather have you looking for other things than Cheyne-Stokes and Kussmaul respirations. If someone's in Kussmaul is the how much time we got? Okay, real quick, because this is likely on a test. What is it? Cheyne-Stokes and Kussmaul. Let's make that blue. Kussmaul. This is for diabetics, right? This is that really fast, rapid, deep breathing. It's not hyperventilation. This is something well beyond that. I've seen it a handful of times, not many. And when you see it, you see it. And this indicates that they're acidic, because if you get too much sugar in your blood sugar goes too high. Your pH will your pH won't go up. pH will go down, right? And so your body's got to blow a lot of that acid off. And then Cheyne-Stokes is the head injury type stuff, where they'll breathe, 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 have a pause, breathe, 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 breathe. Okay, so how do we keep these? This is head injury. Oh, I got the sniffles. Sorry about that. Okay, here's how I keep these two apart. The head injury, Cheyne-Stokes, is rapid breathing with a period of no breathing, and then rapid breathing. So you can kind of play along with the words, right? And then there's a little pause in between them. So Cheyne-Stokes is rapid deep breathing with a pause with some apnea. That's what we call no breathing. And then another series of rapid breathing. Kussmaul is just rapid. Right? It's just rapid breathing. So it's just one word, and it's just all rapid breathing. Kussmaul has got S in it. Well, I suppose that's got S in it too. I always think Cheyne-Stokes, C for cranium. It's just some stupid little things, and then if you say, oh, there's two S's in here, the sugar's really high, right? So just some dumb little tricks to help you remember those. I hope that helps. Let me know if that helps. You guys think you're the only one getting critiqued and doing this? I know how I learn, but I don't know how you learn. So if this doesn't help, or if you need something explained better, I'm all ears. I really am. But that's my little trick for that. Boop. Okay. So breathing, we check the rate and the quality. Now quality, you could say this is going to be, so the rate obviously is the rate, right? We should normally be breathing between, 12 to 20 times per minute, right? So what do you think, if someone's in respiratory distress, what do you think is going to happen to their rate? Well, obviously it's going to go up. The rate is going to increase. And not just by a little bit, but quite a bit. Easily double, triple, quadruple, right? Okay. Now the quality, what do we mean by the quality? This is more the depth. What we call the tidal volume. And that's how much air we're breathing in one breath. And if you can think of like a tide coming into the shore, right? Tidal volume. It's a terrible wave. So the depth, is it shallow or super deep? Again, your normal relaxed breathing should be just that. It should be relaxed. And then we look at the quality in terms of speech. Oh my goodness. You're going to get used to seeing that, folks. Hey, go away, side panel. Speech. Does it support easy speaking? You can get something called dyspnea. So dys is dysfunction, pnea is breathing. So dysfunctional breathing. Dyspnea is what I refer to as the shorter breath. There are a couple different, you can have shorter breath where I can only speak a few words per breath. That's short of breath. And then there's the respiratory distress, as I sniffle in the microphone. And that is someone who is working really hard to breathe and is in the tripod position. I differentiate between those two at work. I don't like this one. This is I'm moving towards respiratory failure. And that is when their breathing is no longer able to support them. When we talk about shock, we're going to talk about compensating shock. That's when your body knows there's a deficit in how it circulates oxygen and nutrients, and so it makes up for that. And the changes it makes to help support that state, they can hold the body for a while, right? And then it gets too much. And once it starts getting overwhelmed, then they go into failure. And this would be death, right? And so respiratory failure is like right there in my own head. They've been in distress. They've been compensating and they've been holding well, but now whatever is going on of them is progressing too far. Their compensating mechanisms either weren't effective or they weren't able to correct what was going on, and now they're into the failure. And if they get too far, there's no going back. Right? So these people, to me, they're in that, right? The short of breath, now we still get worried about it. We don't not treat that. I'm like, oh, you're just short of breath. I don't care about that. It's not that. It's just we think of different things, right? I think of different things with that. I actually go more cardiac when I think of short of breath. We'll talk about that in the cardiac chapter. So the breathing rate and quality. Another thing, I want to go back real quick to the general impression, and I want to look at their behavior. Real quick, I want to back up their behavior. Now, if someone was in respiratory distress, if they couldn't breathe, and maybe you've been there yourself, or you know someone who has, how do you think their behavior is going to be? Now, we always think of like unconsciousness, but losing consciousness from difficulty breathing, you're beyond failure now. Like that is you going into failure, and you're, So we think of, the more dramatic presentations might be the later in the process. One of your earliest signs of hypoxia, and that is where the cells have zero or little oxygen in the cells. Oxygen's not getting to the cells. That's hypoxia. Hypoxemia is low O2 in the blood. All right, emia is blood. Hypo is low, ox is oxygen. So hypo is low oxygen state. That's the A. Hypoxemia is low oxygen blood state, right? So the first indication of hypoxia is a change in behavior. And this can range. This can become panicked. This can become confusion or disorientation. Right? So you look at changes in behavior, real big. This can progress into violence. Like someone's trying to protect themselves, violence. Or they get what we call air hungry. Well, they'll be in such a panic, in such a state. That lady I talked about with her oxygen tank not being connected appropriately, she was very air hungry. She was grabbing at us. I mean, she had no idea what she was doing, but she was so desperate to get a breath of oxygen that she was going air hungry. And she wasn't necessarily violent, but just she was in a rescue herself state. All right, I wanted to back up on that, their behavior. So they might be ANO times 4. In my opinion, that's not enough. Alert and oriented times 4, person, place, time, event, not enough. You got to add behavior in there. And behavior should clue you in. Is this normal for this patient? Okay, so we've covered the breathing, the rate, the quality. Whenever you walk into a breathing situation with a patient, one of your first assessments should be lung sounds. And with both asthma and COPD, we might hear a few things. We're going to hear wheezing with both of them. Because remember, wheezing is from the constricted airways. That's air trying to squeeze past narrow passages, or move through narrow passages. And that happens in both asthma, the bronchospasm, bronchoconstriction, and mucus happen in both asthma and COPD. Now, this is an air trapping issue, right? This is an obstructive airway. In both asthma and COPD, air can't get out. And if air can't get out, it means it's going to back up. It's going to be blocked. Now, they can still get air in until those airways are completely full, right? And so if these airways, oh, look at that, my beautiful drawing. I didn't erase this from earlier. Let's look up here real quick. And I know I'm hitting up on about 15, 16 minutes, but this one might be 20 minutes long just because it's important. Now, if normally, where's my blue? There's my blue. If normally we're breathing air and air's moving in, but the airways are open, the turbulence is going to be fairly minimal, right? And that's on the way in. And then we're going to go on the way out. And so when you listen to the chest or to the lungs with the stethoscope, you're hearing that slight bit of turbulence going through those open airways, right? But now we're going to constrict these airways. We're going to make them smaller, and we're going to make that turbulence even worse. And so you can hear that, or what you're really hearing is the air speeding up through the narrow passageways. That's the whistling, right? But let's think of this. Let's have two airways. One way up here, and here's the alveoli, right? And then one way down here. And another one up here. How about that? And these are going to go to the same thing, okay? And we got this one airway. And we're standing upright, and we're going to start to have some airway issues. And I'm going to occlude one of my airways. All right, so here we go. If I occlude that, and now I'm putting all these big, I'm trying to breathe hard, I'm breathing hard and hard, my alveoli are damaged, sorry, so I'm going to inflate them, but they're going to be a bit loose, right? So they can be hyperinflated, but a bit loose, to where they're not pushing back, but now I'm going to hyperinflate these because I'm breathing in. Big, deep breaths, lots of pressure, and those alveoli might get a bit inflated. But the air can't come out. It's getting in, but it's not coming out. And so the blockage is down here. Now air's still coming in here, but it's hitting this air that's already in here. And so we're getting air trapping. All right, and now we're going to trap that air up into here. All right, and so we're still moving air in these parts, but the air's filling up. It's trapping in here. So if you were trying to listen to this area with the stethoscope, what might you hear or not hear? Well, there's not much air movement since that air's getting trapped. So air's not moving in and out of that. So in certain parts where this constriction is worse, you might actually have diminished or absent lung sounds. And that really depends on how bad it is, how long it's been progressing for during that episode. So some really simple things. Oh, and then one more thing about their breathing. Oh my gosh, you can tell it's getting late. The quality of the breathing, their expiratory phase of breathing is going to be longer and more forceful. Oh, that might not too well than that. So think of this real quick, and then I'm going to be done with this one because it's getting long. Why would it be longer and more forceful? Well, you're trapping all of that air, yet you're still trying to get that air out. And so in order to do that, those airways are closing up. You're going to try to force that air out. You're going to have to recruit your accessory muscles. To try to push that air out. And if you're trying to push all this air out through narrower passages, it's going to take you longer to do that. Right? You might have more forceful inhalation as well because you're working harder to breathe. You're working harder to try to pull that air in, to try to get more air. But you're really trying hard to get that out. Now, if you're recruiting all these accessory muscles and you're working really hard to breathe, you're in distress and you got labored breathing, What do you think that's going to do to their ANO times 4 in their behavior? Well, these people get exhausted. Just as if you're working out at the gym and you're running hard and you're using all these muscles you're not normally used to using, this is going to tucker you out, and these folks get tired. I'm talking they can't take another step without supplemental oxygen. They are absolutely wiped out. And these people will stop breathing on you. They really will if it gets too far. And remember, these folks, especially with COPD, this is a chronic disease. These folks are used to it. They're used to breathing terribly. And so these people might just say, oh, it's just another attack, it's no big deal. They might wait for days. I've had them wait 5 days before they call me. And by the time I get to them, they can't take another step. All right, this video has gone about 5 to 6 minutes longer than normal. Thanks for sticking with it. I hope this helps, and let me know if you got any questions.